Hi, everybody. Welcome to You, Me, and Sacred Birth, part two. Um, we are very grateful that you are joining us this evening or wherever you are in the world right now. I am Dr. Karen Scott. I am the Chief Black Feminist Physician Scientist, founding CEO, and owner of Birthing Cultural Rigor. So again, thank you for joining You, Me, and Sacred Birth, a virtual book reading and a Q&A series, session two, part two, manifestations of anti-Black racism and misogynoir. Today's theme will be around equal pain, separate care, mapping the mechanisms of unmitigated Black suffering. Um, we're going to give people probably like a little bit to 5 minutes afterwards just to make sure as many people that can join. The session will be recorded and it will be made available to you on our Birth and Cultural Rigor YouTube channel, as well as the website for The Educated Birth. Founder and creative director is Cheyenne Varner, who's the owner of The Educated Birth, will be with us today as our host and moderator. And then we also have Julia Scott, who serves as Birth and Cultural Rigor's marketing and tech consultant. Again, welcome to You, Me, and Sacred Birth, a virtual book reading and Q&A series, session two, part two, manifestations of anti-Black racism and misogynoir. Equal Pain, Separate Care, Mapping the Mechanisms of Unmitigated Black Suffering. This is part of an 8-part series that I'm offering for free virtually to facilitate people's awareness, their involvement and engagement with the book reading, as well as hopefully compelling folks to purchase the book, as well as speak positively about the book in academic, community, government, and industry spaces. So we're going to go ahead and start. The format usually is we do a welcome introduction. Again, Cheyenne Varner, thank you so much. The founder and creative director of The Educated Birth is our host and our moderator. And then Julia Scott serves as Birth and Cultural Rigor's marketing and tech specialist. We will do the welcome, and then we move into some anonymous online polling to get a sense of what this particular group of people, your perspectives on equality, patient safety, and today would be racism, anti-Black racism, and misogynoir. I will read a few pages from our book for about like 30 minutes, and then we'll leave a screen on for you to see where you can post your questions, your concerns, or comments throughout the reading. Once I am done reading, we'll leave a little bit of time, about 15 to 20 minutes of Q&A, where I will go through the comments and Q&A that I see on the screen. And then Cheyenne will help us with any questions or comments that are left in the chat box or the Q&A. So again, welcome to You, Me, and Sacred Birth, Part 2, Chapter 2, Equal Pain, Separate Care, Mapping the Mechanisms of Unmitigated Black Suffering. Thank you to Cheyenne Varner from The Educated Birth, founder and creative director. Here is, kind of some market information about The Educated Birth. You can follow them at www.theeducatedbirth.com. Also online at The Educated Birth. We support you as you support parents with inclusive teaching tools for pregnancy, birth, and postpartum. Again, Julia Scott, thank you for being our BCR marketing and tech specialist. So we will go into our online polling activity first, and then I'll read from chapter 2, and then we'll have a little bit of Q&A. Again, thank you for joining. In the chat, you will see, and on the screen, you'll see instructions that says join at menti.com. Use the code 16394924. We'll go through a series of questions kind of quickly. You'll see the data from your responses in real time through real-time data visualization in the form of either a word cloud or open-ended responses. And then we'll go into the reading. So feel free to respond as truthfully as you want to, because no one will know unless you tell us. We have about 10 people on the line. So as we get up to about maybe 5 or 6 people who respond, then I'll move to the next question. It is 7 after the hour. I do hope to have us end on time. I could say a little bit afterwards. But thank you so much for joining. And thank you for responding. Shout out to Virginia, Maryland, California, and New York. So for the next question, again, it's open-ended. There is a limit to the characters. I don't remember, maybe 220 characters. If you are joining us, thank you. Welcome to You, Me, and Sacred Birth, Part 2, Chapter 2, Equal Pain, Separate Care, Mapping the Mechanisms of Unmitigated Black Suffering. As you join us, again, we are our host and facilitator, moderator today is Cheyenne Varner, who is the founder and executive creative director of The Educated Birth, and then Julia Scott serves as BCR's marketing and tech specialist. So as you join, we're going to do some online polling to get a sense of your perspectives on quality, patient safety, and various forms of racism in care. And to get a sense of who you are, I'll go into the reading and then we'll do some Q&A. So the next question is, why are you joining us today? Please feel free to respond. Again, this will be real-time data visualization in the form of either a bar graph or a pie chart or just a series of open-ended questions, narratives, or word cloud. And again, I will hope to get us to end on time. We may go over by 10 or 15 minutes. But again, thank you for joining today. And thank you to the first responder who's a doctoral student and fan of Dr. Scott. Does anybody else want to enter their reason for why they're joining today? Again, join at menteeth.com. You will see on the slide at the top of every single slide will be these instructions with the code. Enter the code 16394924. Another response, thank you so much, is to really get a deeper, better understanding of the issues with obstetrics from someone who's been inside the system. Again, thank you for your response. Does anyone else want to respond before I go forward? This link will be available to you. The duration of the night for you all, where I am, it's about a little bit after 2 p.m. So you can continue to add your responses. Someone else has responded, new OBGYN wanting to learn. I've been following Dr. Scott's work for many years. Thank you, thank you, thank you. Someone else, I'm excited to hear your perspective on how anti-Black racism and misogynoir manifest in birthing experiences. Someone else is a doctoral candidate, a social scientist, and a therapist, and they've been following me in my work for some time. Again, thank you all so very much. This is very affirming. Again, Sacred Birth is available. The link also will be in the chat for you to purchase. It is an academic textbook with academic textbook prices. If you purchase directly from the publisher, you'll get a 30% discount. All the information is in the chat. Someone else has responded, continuing to learn and build with my sister friend Scotty. Thank you, thank you, thank you all. Let's keep going. Okay, so for now, as much as you can, identify one word that comes to mind when describing mothers and birthing people. Any one word, and this will be real-time data visualization so that the word that you all use most frequently without having had shared your word with each other will be the word that's in the center. It'll be the largest word. And as other words come to mind, those words will be on the periphery if they're not used as frequently by this particular audience. Thank you, first responder. The first word that comes to mind is sacred. Does anyone else have any other thoughts around the first word that comes to mind describing mothers and birthing people? Again, thank you for the use of the word sacred, followed by powerful and joyful. Again, normally these are words I don't always see, so thank you for that. Again, the 4 people who've responded, we see strong, we see strength, we see sacred, we see powerful, we see joyful. And does anyone else want to add anything else? We see vulnerable here as well. Give it a couple more seconds and we'll keep going so that we can get through these questions just to help ground you in today's discussion for this particular chapter, but also around the overall limitations and possibilities for redefining what our current obstetric quality and patient safety paradigm could be. All right, we move to the next question. Again, if you're joining us, welcome to Sacred Birth. You, Me, and Sacred Birth, Part 2, Chapter 2. We're doing our online polling anonymous activity to get a sense of what your thoughts and beliefs are. So come and join into this space. Again, you can start responding now. Join us at menti.com. Use the code 16394924. And you can start participating. We're going to do this for a couple of minutes to let people still come into the space. Again, join at menti.com. Use the code 16394924. Welcome to You, Me, and Sacred Birth, Chapter 2, Part 2. And we're just doing some online anonymous polling about your thoughts and perspectives with real-time visualization of your responses. So now we're at the question, identify one word that comes to mind when thinking about quality of care. You can start wherever you want at the beginning and catch up. This link will be open for the duration of the evening. Thank you to our first responders. The first word that comes to mind when you all are thinking about quality of care in the center, which would be the word that's used most frequently. And right now they are all the same size. So maybe we have 5 different responses from 5 people. So we see necessary, we see respect, we see inconsistent, we see traumatic, we see lacking. Mm, Absolutely. We see multifaceted. Again, see, these are some of the words that I have not seen, although I've only done this particular activity with this phrase like twice. So thank you for your response. You can enter again if you want to. Identify one word that comes to mind when thinking about quality of care. There aren't any other words, so we'll keep going to the next theme. Okay, we'll keep going. You can continue to respond. Now, identify one word that comes to mind when thinking about childbirth in hospital settings. What one word comes to mind when thinking about childbirth in hospital settings? Medicalized, absolutely. Thank you, first responders. Sterile, yes, I wholeheartedly agree. And again, if you're joining us, we're just kind of grounding ourselves in the work in my particular scholarship that interrogates and challenges the existing obstetric quality and patient safety paradigm. But I also want to hear from you all to get a sense of what your perspectives are, your feelings and thoughts about quality, patient safety, birthing in hospital settings. So now we're at the question that says, identify one word that comes to mind when thinking about childbirth in hospital settings. We're using a word cloud. So the word that is most frequently used based on the people who are responding would be the largest word, and it'll usually be in the center. And if the words are all the same size, it means that everybody has, right, utilized that one word one time. So it seems like we have 5 different responses, 5 different words, and we see medicalized, sterile, limited, dangerous, unsupported. Again, these are your current perspectives about childbirth in hospital settings. And again, this is to kind of ground you in this sense. It's in a webinar fashion, so you may not be able to talk to each other, but you will be able to get a better sense of who is in this virtual space with us. And again, thank you for joining. The next question, in your own words, describe the meaning of being safe. Again, in your own words, to use more than one word, describe the meaning of being safe. What does being safe mean to you? And whatever first comes to mind around what does being safe mean? Thank you, first responder. So being safe is to be heard. Does anyone else have any additional thoughts? You don't have to write a lot, just whatever first comes to mind in terms of your feelings and your thoughts. Again, thank you for responding. Being safe for this particular group means being recognized, it means body, mind, and emotions safe. It means listening to and respecting my needs and rights. And again, as I ask this question, I would like for you to also consider, right, that right now we have these four different meanings of being safe. Think about the existing press, Gainey, HEDIS, CAPS, HCAPS measurements, right, that we currently utilize in healthcare to evaluate the performance of hospitals, as well as to assure their reimbursement. Do these four existing definitions right now of being safe, are there current tools that allow us to measure being safe as being heard, being recognized, listening to and respecting my needs and rights, being seen, valued, and heard, body, mind, emotions? I'm unaware of any tools that exist, but if you can think of some, please put it in the chat. But again, these are your thoughts around what it means to be safe. And I'm here to say, I'm not sure what you believe to what it means to be safe is actually captured by these current health systems and insurance companies. So now let's move into, in your own words, describe the meaning of feeling safe. Again, feeling safe, not being safe. Then in your own words, describe the meaning of feeling safe. Trust. Thank you, first responder. So to feel safe means trust. Anyone else have any additional thoughts or feelings, comments, definitions? Feeling safe means being respected. Thank you. Feeling safe means comfortable. Anyone else want to add their thoughts around the meaning of feeling safe? And we have three more questions, and we'll move into the readings. And part of the reason why I do this is to demonstrate that the systems have a kind of a topology. They have meanings and manifestations and measures of being safe. That's usually defined by the system. Whereas when we think about what it means to feel safe, feeling safe is defined by patient experiences and community wisdom. And a lot of times there is a misalignment, a tension, a conflict between being safe as defined by the system compared to feeling safe as defined by patient experiences and community wisdom. So I do invite you to check out the first recording of chapter 1, part 1, so you can get a better sense of why it's very important that we supplement our current measurements and meanings and manifestations, even reimbursement, to the evidence of feeling safe, because one can be safe in a system and feel unsafe, but the system will never capture those feelings of unsafety because they focus so much on being safe, which is a check mark, right, of these kind of outcome measures. The last three questions are about kind of the three things that we're talking about today: racism, anti-Black racism, and misogynoir. So what does racism mean to you? How does racism show up in care? I know that's a loaded question. I don't want you to overthink it. Just immediately what pops into your mind around what does racism mean and how does racism show up in care? You can talk about it broadly in primary care, healthcare, specialty care. You can also talk about it in response to obstetric or perinatal or neonatology or infant pediatric care. But if you could sum it up as briefly as you could, what does racism mean to you and how does racism show up in care? Thank you for responding. You went straight to anti-Black racism, so thank you. Anti-Black racism is a dehumanizing force. One way it shows up in care is through a lapse in response to a Black patient's needs. Absolutely. Thank you so very much. So again, it doesn't have to be long. Just what are your immediate thoughts and feelings when I ask you to define racism? And then how does racism show up in care? If one other courageous person could add their response, and then we'll just move forward. And again, you have time to write your response, even as I begin reading from my chapter, you can always go back and add more responses. So thank you, second responder. Differences in attitudes, tone, decision-making, diagnosis, lack thereof, etc., between care and patient. Thank you so very much. Does anyone else want to be courageous or curious to just post what racism means to you and how racism shows up in care? Thank you very much. Systems, policies, and people with beliefs that excludes, oppresses, and violates can be implicit bias, internalized oppression, and white supremacy. Again, thank you all, first responders. I'm going to move forward, but you also have time to enter your responses throughout the duration of today's talk, as well as this evening. I'll keep the link open. Now, thank you, the first responder to the last question who went straight into anti-Black racism, because racism is not the same as anti-Black racism. So what does anti-Black racism mean to you? And how does anti-Black racism show up in care? Again, it is a provocative question, but I just want to get a sense of what this group is thinking. If someone dares to be courageous enough to post your response, as others can also hope that you are in a place of curiosity, that you can receive these definitions and consider how you would either rework your own definition or rethink the way that these forces, these systems of oppression, how they show up in care. Again, what does anti-Black racism mean to you? And how does anti-Black racism show up in care? If somebody wants to post what they wrote the last one time, you can do that as well. Thank you, first responders. So for this particular person, how does anti-Black racism mean to you? And how does it show up in care? They wrote how I'm spoken to and looked at. Absolutely. Thank you very much for sharing. Does anyone else want to provide again your own anonymous definition or meaning of anti-Black racism and how it shows up in care? Again, thank you, second responder. Anti-Black racism is specifically about dehumanizing Black people and occurs on a global scale. Anti-Black racism reveals itself in care through relying on dehumanizing stereotypes about Blackness. Thank you. Thank you. Again, thank you for your responses. Thank you, third responder. Um, direct specifically towards Black people based on misconceptions and lack of respect and understanding. Again, thank you all. One last question before I start to read. What does massage noir mean to you? And how does massage noir show up in care? And this is, reflecting on Moya Bailey's definition of massage noir. Um, that she defined, I forget the year, but she defined it first in with a colleague around describing the ways in which the vitriol, like essentially the hatred and vitriol towards Black women in digital spaces. She wrote a book about it as well. And so there is the opportunity to consider how anti-Black gendered racism shows up specifically against Black women in care. So when we look at the intersections of race plus gender, or racism and gender oppression together, and other things, right? Giving you hints. So thank you, first responder, hatred towards Black women. And how does this show up? How does this vitriol, hatred, dehumanizing care, disrespect, neglect, mistreatment, how does misogyny show up in care? And this will be the last question, and I will go straight into reading from chapter 2. Thank you all, first responders. Dismissing concerns of Black women, lack of response to pain, disbelief, and express symptoms. Thank you so very much. Anyone else want to share before I start reading? Thank you. Not listening to Black women at all, especially in healthcare, negating our concerns, sending us home, dismissing our pain. Thank you. Masculine superiority over Black women stereotypes. Thank you so much. Misogyny is a specific discrimination that Black women experience. What Black women experience in terms of hate is not just racialized, but also gendered. Thank you all so very much. And last one, again, you have time throughout my talk to go back and add to your responses if you want to add new responses. But as we end this part, now think of one word that comes to mind when describing Black mothers and birthing people. One word that comes to mind when describing Black mothers and birthing people. Again, this is anonymous. We will not know what you shared, but we can get a sense of the group of people who've gathered today in this virtual space. And once we're done with this, the next slide will be the link so that you can post comments, questions, ideas, feedback as I begin the reading part. Thank you all so very much. The first two people with your words, three people, Afrofuturism. I have not seen that at all. Resilience, royal, worthy, beauty, beautiful. Thank you all so very much for these words, so life affirming. Usually, when we get to describing Black mothers and birthing people, the words actually become very life negating. So I do appreciate for the first time that we don't see that at this moment. It doesn't mean that you can't put it, but I do this work to show how people can think very positively about mothers and birthing people in general. And as soon as we racialized mothers and Black people to being Black, their thoughts, their life affirming beliefs and perspectives kind of go away. So I appreciate that. But again, please feel free to respond when you want to. Okay, I forgot I got more questions. These are quick. Just to get us into who you are. So we saw how people responded. What is your primary role in your daily work? Are you an advocate, administrator, practitioner, researcher? My role is not listed. If your role is not listed, please put it in the chat and I'll mix some of these responses up. But again, thank you first responders. And again, as you respond, you'll see in this bar graph that we have real-time data visualization. So we'll see that out of the 5 people that responded, we have the majority of people are practitioners. We have advocates, we have administrators. So thank you, thank you, thank you. Keep responding. We'll go to the next question. What is your primary racial identity? This is a Black focused space. And so I do Black or non-Black. Are you Black or African American? Black multiracial? Non-Black multiracial, non-Black. So many times when I enter into spaces, they are usually dominating spaces for other groups, racialized groups, and I'm othered. So I wanted to just have an opportunity to other people. So out of the 5 people responded, they're identifying as Black or African American. Again, how will you describe your gender based on the options I have provided? Because I still wanted to be able to be inclusive, but also not have so many lists that are there. If you identify as gender non-conforming, non-binary, gender queer, or gender fluid, there's an option for you. If you identify as a cis or trans woman, there's an option for you. A cis or trans man, there's an option for you. And then if you believe your gender is not, identity is not listed, the option is there as well. But thus far, out of the 3 people that responded, 100% identified as woman. So here we go. So thank you so much. We're going to begin the reading part. You can go back to enter more responses as I read. I'm going to hopefully get through this in 20 to 25 minutes. I'm going to set my timer because I do want to be able to leave time for you all to ask questions. So I'm going to start reading from chapter 2, page 43, racism, which is a Black patient identified quality domain and the Sacred Birth Quality Framework, where the R is for racism. So chapter 2, manifestations of anti-Black racism and misogynoir. The daily denial of the role of racism, specifically anti-Black medical racism and anti-Black misogyny or misogynoir, in the examination of Black women's perinatal deaths, reinforces the lie that race is a biological construct. More importantly, racism denial in society, and that comes from Dr. Kamara Phyllis Jones in her 2000 publication, in public health literature and in obstetric quality and patient safety literature, facilitates the creation and spread of mother blame narratives. Essentially, mother blame permits professionals and their corresponding organizations in public health, medicine, nursing, epigenetics, medical risk and liability, quality and patient safety to place the onus of disparate deaths, near deaths, and disabilities on the individual behaviors and individual choices of Black mothers. Consequently, fundable research, improvement, implementation, and policy initiatives focus exclusively on screening, surveillance, and control of aberrant Black behavior as solutions to save and protect Black children. By blaming individual choices and behaviors instead of addressing the oppressive and inhumane structural, socioeconomic, and political conditions that shape Black mothers' options and opportunities to experience life, liberty, and the pursuit of happiness, then these very systems and structures never have to do better. According to Dr. Kamara Jones, in her very compelling explanation of the levels of racism using the allegory of the gardener's tale in the 2000 peer-reviewed publication in the American Journal of Public Health, institutionalized racism is often evident as inaction in the face of need. Based on the evidence as reported from 1900 to 2023, again from 1900 to 2023, in action to name racism, structural racism, institutional racism, interpersonal racism, internalized racism, gender racism, obstetric racism, in the face of needing to explain persistently worsening racial inequalities, inequities, and injustices in experiencing life, liberty, and the pursuit of happiness through pregnancy and childbirth is, in fact, institutionalized racism. Like the fathers of gynecology, the fathers of perinatal and maternal quality improvement assigned a higher value and visibility to the expressions and experiences of white male physicians or any person adjacent to or protective of whiteness, a practice called epistemic redlining. By establishing a hierarchy of knowing and knowledge that relegated Black women silent or silenced through disease, disabilities, and deaths, systems and structures excluded or erased Black women's voices, intellectual thoughts, and activism through the support of philanthropy and funders. In resistance to and refusal of the silence and silencing of Black women as patient, community, and content experts, we invited Black mothers to reclaim the sound and movement of their mouths. We curated sacred spaces of connectedness and psychological safety, honoring Black women's innate worth as human beings. In holding sacred spaces for Black women's innate worth, in holding sacred spaces for Black women to speak and the sound to be heard, received, recorded, transcribed, interpreted through a Black feminist hermeneutic phenomenology, remembered and shared with informed consent feels like doing the work of God. The privilege and responsibility of translating stories into strategies to transform the obstetric quality and patient safety paradigm is spiritual work. Listening to and learning from and with 37 Black women changed me in immeasurable ways. What these brilliant, bold, and beautiful Black women created stands as the first and only shared language and understanding of the meanings and measures of racism, specifically anti Black medical racism and anti Black misogyny or misogynoir during pregnancy, childbirth, and postpartum. The four most common meanings of racism during pregnancy, labor, birth, and postpartum included number one, perpetuation of an anti Black racist stereotype about Black people that adversely impact service, support, and care provision and utilization. That is the anti Black medical racism. Number two, perpetuation of an anti-Black misogynistic stereotype about Black women or Black motherhood that adversely impacts the provision of affirming care or utilization of care, services, and supports. And that is anti-Black gender racism or misogynoir. And number three, different differential birth care, outcomes, and experiences based on differential access to and utilization of services and supports, including certified nurse midwives in relation to hospital births, and doulas, particularly the Black and Brown birth workforce, and life affirming versus life negating state resources, such as Black infant health, child protective services. Three specific scenarios or narratives of anti Black medical racism and misogynoir dominated the individual responses and focus group dialogue. First, Black mothers and birthing people feared conforming to historical and contemporary stereotypes, such as the angry Black woman, or being labeled in patient sign offs or the health record as too demanding or difficult patient if they persistently asked for help or clinical attention after initial and or prolonged periods of clinical neglect, indifference, denial, dismissal, and or delay. Subsequently, Black mothers and birthing people modified their behavior, attitude, language, or appearance to avoid any type of negative interaction or experience or other forms of retaliation, such as worsening care, involvement of hospital administration as a form of censorship or silencing, and punitive actions such as involvement of security, CPS, psychiatry, mental health, or police law enforcement to facilitate the separation of the Black mother from her child, her partner, her mother, her maternal grandmother, her community doula or midwife, or any other community support person without hospital affiliation or alignment. Second, Black mothers also discuss ways in which Black men are masculine presenting partners and loved ones, modified their behavior, attitude, language, and or appearance when wanting to appear more accepting to the white gaze, white authority, or any dominating figure on the hospital team in proximity to whiteness, particularly during periods of advocating for self, partner, and or baby. The self-imposed transformations as well as code switching occurred as protective strategies to avoid conforming to the historical and contemporary stereotype of Black brute or animal-like savage. Third, Black mothers express the fear of conforming to the narrative of being a drug seeker, reminiscent of the historical crack epidemic, if they dare to ask for or eventually demand the initial, subsequent, or prolonged administration of general analgesic or opioid medications. The majority of the quality violations during pain mismanagement occur in the setting of Black suffering and inadequate pain control associated with labor contractions, rough handling of the Black body during a cesarean birth, and postoperative pain control after cesarean birth during hospitalization. The details of the language, attitude, and behavior of hospital physicians and nurses represent a stark contrast to the contemporary opioid epidemic response in the afterlife of slavery, the crack crisis, and the war on drugs campaign. The contemporary response to the opioid epidemic includes an abundance of empathy, grace, humanity, dignity, and resources, including forgiveness and restoration, extended to a different group of mothers racialized as non Black. Thus, Black mothers in pain for medically related and valid reasons avoid seeking help or clinical attention even after major abdominal surgery, such as a cesarean birth. Black mothers in Oakland and Los Angeles feel that anti Black medical racism and misogynoir show up in clinical and social interactions, communications, consent, decision making, and documentation and dissemination of healthcare information in patient sign offs, patient handoffs, and electronic or paper health records. Anti Black medical racism and misogynoir manifest in the following two ways. Number one, differential access to and utilization of birth resources, pain management options, visitation policies, senior staff for procedures, consent, refusal, and the four T's: time, trust, truth, and transparency to make decisions. And number two, the presence and proliferation of language, actions, and behaviors by hospital administrators, clinicians, and staff rooted in myths and misconceptions that Black people don't feel pain, have a higher threshold of pain, or exaggerate their pain, creating barriers and burdens to optimal clinical recognition, responsiveness, and resolution, and overall birth experience around pain mismanagement. One of the dominant experiences of harm, one of the dominant experiences of harm enacted through isolated or repeated violations of safety and accountability, autonomy, specifically decisional and bodily autonomy, informational autonomy, care autonomy, communication and information exchange, empathy and humanity, and dignity and Blackness and holistic care was, is, and remains the mismanagement of Black pain and discomfort. Repeatedly, the evidence shows that failure to end Black emotional, mental, cultural, or physical suffering in the provision of obstetrics care is one of the most insidious and impactful tools to break the human spirit, individually and collectively. Institutionalized racism is often evident as inaction in the face of need. Dr. Kamar Jones, PhD, MPH, MD. In my own attempts to understand how the lack of oversight, accountability, and justice toward the inhumane conditions of experiencing and navigating pregnancy, labor, childbirth, and postpartum while Black, I had to consider the motivations for ignoring Black suffering while creating Black suffering. And I was not the only one thinking about the motivations and justifications of inaction. When asking Black mothers why they believe hospital clinicians and staff treat them differently as Black women compared to the treatment of white women and act without any remorse, oversight, or accountability, one particular response from a Black mother in Los Angeles comes to mind. You push out the baby, and then you go back on the fields and you keep picking the cotton. I am in pain, but you're looking at me like I don't feel pain. I'm just being ignored. I'm talking, but nothing's coming out of my mouth. Her critical reflections of her own hospital experiences affirm and justify ethical, epistemological, and methodological approaches to examining atrocities of the U.S. maternal health systems and structures through histories that track along anti Black racism and eugenics in the afterlife of slavery at the intersection of medical racism and obstetric violence, which is Davis's analytic and phenomenon that she first defined in an online publication December 18, Obstetric Racism. In the context of Black mothers exploring the motivations for the rise in forced inductions and forced cesarean births among Black mothers, and the widespread unmitigated dismissiveness and denials of Black suffering, combined with the lack of motivation to end Black suffering involved in a spontaneous or forced birth by way of forced pregnancy in the afterlife of slavery and in a post-obs world, this is obstetric racism, and capitalism is the driver. In describing one meaning of anti-Black racism in obstetrics care, Black mothers stated that racism is the perpetuation of a racist stereotype of about Black people in general and Black mothers in birthing communities in particular, held by hospital clinicians, administrators, and staff, in public or private, that adversely impacts the provision of hospital based perinatal services, care, and support in three key areas. The corresponding belief and behaviors show up as hospital administrators, clinicians, and staff hold myths or misconceptions that Black people don't feel pain or have a higher threshold of pain, again, creating barriers and burdens to optimal clinical recognition, responsiveness, and resolution, and the overall birth experience. The dominant exemplars for demonstrating the presence and permeation of anti Black medical racism in obstetrics focus on the mismanagement of pain during and after childbirth particularly among Black mothers who utilize the epidural during a vaginal or abdominal or cesarean birth. So here's a dialogue between Keisha and Jada, two of the, it's actually 36 Black mothers in Oakland and Los Angeles. So here in Oakland, Keisha, oh yeah, my C-section was planned, but I had a really bad experience because they were expecting me to be okay with the pain because I had a couple of prior surgeries. So they read my history and were thinking that, oh, let me just brush her off because I could feel it, like my husband was there. I could feel it going so hard. And then after I asked her a question, I said, why were you going so hard on me? Because I could feel it like, oh, you got a lot of muscle. I said, that's not an excuse. And also with the painkillers, she was like, oh, one of the nurses was like, I don't think you need this. I said, I'm in pain. Yeah, like now you're thinking for me because they read that, that I had surgery before, that I'm used to the pain. I'm like, I'm really in pain. Like I need something right now. So yeah, Jada, you had a lot of muscle. Come on. Keisha, yeah, I said there's no muscle there. It's all weight. So, and then I asked her a question, but they always had an answer for something. Again, two Black mothers in a focus group dialogue, March 2019 in Oakland. Through the speaker's story of a planned cesarean birth in the context of a history of prior abdominal surgeries, one learns of the audacity of the obstetrician as a primary surgeon to dismiss their patient's explicit and expressed discomfort during a major abdominal surgery, to boldly ignore the patient in the presence of the husband in the operating room shows an even greater level of arrogance combined with a lack of fear of harming a Black mother. The primary surgeon's confidence and comfort in knowing the nurses and support staff would remain complicit in the violation of a patient's ethical and legal right to optimal pain management during a major abdominal surgery speaks volumes. When reflecting on the white gaze of white physicians and nurses upon Black bodies, one wonders what is that thing the white health professionals they force themselves to see or not see when they gaze upon the dark bodies of reproducing, birthing, or lactating Black people, particularly the same Black bodies within the context of pain and suffering. Again, Dr. Kamara Jones asserted in her 2000 publication that inaction in the face of need is institutionalized racism. When Keisha persisted in her inquiries to the primary surgeon about the rough nature of the surgery, the primary surgeon identified characteristics of the Black mother's body, a lot of muscle or dense adhesion, scar tissue from prior surgeries, as the reason for suboptimal intraoperative pain management. In this situation, the racism escalated as the primary surgeon participated in the medical mob mentality of displacing blame and accountability for suboptimal pain control onto Black bodies. In this series of harmful clinical interactions, we see the manifestation of Davis's obstetric racism as a tool of anti-Black medical racism through the reproduction of neglect, intentional causing of pain, and medical abuse. The lack of recognition and response to persistent pain during and after major abdominal surgery by the primary OB surgeon, anesthesiologist, and the entire OB surgical team of nurses and support staff represented neglect, dismissiveness, and disrespect when medical professionals ignore or dismiss a person's expressed need for reproductive help or care and or treat them with disdain. Keisha shared additional details about the unsolicited banter and judgments imposed onto her condition that only further dismissed her suffering and diminished her valuation of being worthy of white benevolence during Black suffering. Oh, you had a lot of muscle. I said, that's not an excuse. And also with the painkiller, she was like, oh, one of the nurses was like, I don't think you need this. I said, I'm in pain. When the primary OB surgeon and the post-operative or postpartum nurse fail to appropriately manage her pain, we must not ignore that the reason for a medical mob mentality and denying, dismissing, or diminishing patient-reported experiences of pain among Black people is grounded in racialized beliefs about pain immunity. Nearly 24 years ago, researchers conducted a study in an urban emergency department, ED, in Atlanta, Georgia, that examined the independent effect of a patient's race or the ED clinician's response to a patient's race in the provision of medical care on utilization of pain medications while controlling for the effect of other factors. The researchers measured the proportion of Black patients versus white patients receiving ED pain medications. Again, ED emergency department. To reframe, the primary outcome was the extent to which ED physicians and nurses reproduce anti Black medical racism and the recognition and response of Black and white patients presenting to the ED with new, isolated, long bone fractures over a 40-month period at an urban ED in a Black Mecca such as Atlanta, Georgia. Data collection required blinding the physician and nurse reviewers from knowing the patient demographic information, including racialized identity and ethnicity. The physician recorded characteristics of the patient's injury and treatment, while the nurse recorded the administration of the analgesic pain medication. Study findings revealed the urban city ED and Atlanta practiced anti-Black medical racism in pain management to Black patients experiencing long bone fractures. The study sample consisted of 217 patients. 41.4% identified as individuals racialized as white, and 58.5% identified as individuals racialized as Black. Yet, in a Black majority study, the sam in a, let me start over. Yet, in a Black majority study sample, the ED physicians and nurses were significantly more likely to administer ED analgesics to white patients compared to Black patients. 74% versus 57%. Again, in a Black dominated sample size for the study. White folks still got more pain medication with a p-value of 0.01 with statistical significance, despite similar or equal records of pain complaints in the medical record. The risk of the ED clinician's response for denying analgesic administration was 66% greater when the ED clinician responded to or cared for a Black patient compared to a white patient. The effect persisted even after controlling for other factors. This was published 25 years ago in 2000. Immediately, equal pain, separate care comes to mind as the simplest meaning, measure, manifestation, and mechanism of anti-Black medical racism and facilitating unmitigated Black suffering in medical spaces. The lack of oversight and accountability in addressing the U.S. standard of equal pain, separate care, based on these data is yet another example of institutionalized racism and inaction in the face of need. Ironically, at the time of writing this particular paragraph, U.S. Congressman and physician Dr. Greg Murphy introduced, and he is a physician. Dr. Greg Murray introduced the Embracing Anti-Discrimination, Unbiased Curriculum, and Advancing Truth in Education, the EDUCATE Act, to ban race-based mandates at medical school and accrediting institutions on March 19, 2024. American medical schools are the best in the world and no place for discrimination, stated Congressman Dr. Murphy. As a dissident and recovering OB physician for 22 years and counting, this is me, who is firmly grounded in Black feminist ethics, ethos, and praxis, I agree with the last part. U.S. medical schools are no place for discrimination, especially if they are beneficiaries of any type or form of federal funds. The discrimination, specifically anti-Black medical racism, and the provision of care for patient expressions of pain extends beyond adult Black bodies. 15 years after the demonstration of equal pain set for care by physicians and nurses in the ED in Atlanta, that's 2000, a different set of clinicians, scientists, sought to address the longstanding history of equal pain separate care in the ED by first considering the possibility of biases including spectrum bias. This is by Goya et al. In 2015. Given the disproportionate use of the ED as a primary source of healthcare for non urgent care, among other reasons, the researchers justified the past evidence as racial or ethnic differences in ED use rather than ED management, as minorities may be more likely to present to the ED for non surgical or less intense causes of abdominal pain. The assumptions and rationale for justifying equal pain separate care continue to displace the onus of suboptimal pain management, specifically the lack of motivation to end Black suffering, on individual unfit Black bodies and behaviors. To eliminate biases, the researchers decided to evaluate pain management of appendicitis. The motivation for this type of evaluation was based on two assumptions. First, appendicitis is the most common surgical cause of pain in the ED or emergency department. Second, the provision of analgesic medication in the ED for appendicitis is accepted and supported as the standard of care. Thus, the researchers decided to examine racial differences. Really, these are racial inequities and racial injustices in management. We'll carry on. In the overall administration of general analgesia and opioid analgesic, after controlling for factors such as demographics, ethnicity, number of visits, and pain score among children aged 21 years or younger in the ED. The study sample consisted of nearly 1 million children diagnosed as having appendicitis. 1 million children, 21 years of age and younger, as diagnosed with appendicitis. To reframe the meaning and significance of study findings, I use active voice instead of passive voice in data interpretation and dissemination. The use of active voice shifts the focus to examining the behaviors of the ED teams in response to children's accounts of pain within the context of manifesting medical racism in the diagnosis of appendicitis and administration of analgesic medications, both general and opioid. The ED teams administered any type of analgesic to about 60% of all children, with the ED teams administering more opioid analgesics to white children compared to Black children, 43.1% versus 41.3%. When examining ED pain management based on children's pain scores and controlled for race and ethnicity, the ED teams were less likely to administer any analgesic to Black children with moderate pain from appendicitis compared to white children reporting equal pain. Similarly, the ED teams were less likely to administer opioid analgesics to Black children in severe pain compared to white children with equally severe pain. After controlling the effect of many factors, the researchers found no statistically significant differences in the overall rate of analgesic administration by race. On the contrary, the odds of administering opioid analgesic medication by the ED team to children in pain due to appendicitis is 80% lower. 80% lower if the ED team cares for a Black child in pain. Independent of ED over or inappropriate utilization by structurally marginalized and minoritized individuals and communities, or ED management of pain for conditions deemed acceptable, the abundance of evidence is clear. Equal pain, separate care is pervasive throughout the U.S. health system, including the maternal health system. A Black mother from Oakland, Rhonda, shared her thoughts on the ubiquitous denial of Black women's testimonies of their pain, particularly during childbirth. I think they automatically think like women of color, like not just women of color, but Black women. Like, oh, you're just trying to use the drug situation and stuff like that. I think that's what it is. They automatically think we're just trying to get the drugs. You know what I mean? And this childbirth thing is a joke. And they think we're lying about our pain or something like that. The ease with which any person indoctrinated into medicine or nursing, independent of race or gender, can willfully, boldly, and repeatedly ignore Black pain is a manifestation of Davis's obstetric racism. When one or more individual healthcare professionals with state issued licenses to practice nursing or medicine fail to appropriately manage pain, then three things can be true. One, the motivation is grounded in racist antebellum popular culture disseminated in many literature realms, including natural and social sciences, for the promotion of domination through subordination and chattel slavery. Two, the acceptance of and possibly pleasure and the onset, duration, continuation, and exacerbation of Black suffering demonstrates an act of bodily terrorism, fueled by the absence of empathy for Black people's suffering, including emotional, cultural, and physical suffering. Three, the lack of internal motivation to alleviate or reduce Black suffering likely stems from implicit biases passed on since the antebellum period and from a lack of systemic or structural oversight and accountability of public being, excuse me, start. Three, the lack of internal motivation to alleviate or reduce Black suffering likely stems from implicit biases passed on since the antebellum period and from a lack of systemic or structural oversight and accountability within the hospital or state licensure agency. The brutality and inhumanity of public beatings to death and lynchings facilitated subjugation. The white gaze upon the Black reproducing body in pain within the context of power dynamics between a hospital physician or nurse and a Black female patient replicates the history of whiteness as terror. The scene is one of spectacle. Gazing upon the despised and violated Black body is also a site of white racist pleasure, masochism, and dominance. Therefore, widespread denials of Black discomfort and suffering maintain control and domination in the hierarchy of humanity. The perpetual denial of Black suffering is also a manifestation of medical abuse, as defined by Davis. Medical abuse can occur when healthcare professionals engage in experimentation and or repetitive behavior that serves to validate the clinician's self-worth and oppose the domination over the patient with no regard for the patient's desires, experiences, or concerns. That concludes the reading of chapter 2. I know we're after the hour. I can stay on for another 10 or 15 minutes if anyone wants to ask a question or share your thoughts. Thank you for participating today in part 2, chapter 2, with our online polling and with the reading. Thank you to Educated Birth for being our moderator and host, Cheyenne Varner, and to Julia Scott, BCR's marketing tech specialist. Any questions, any comments about today's reading? You can enter it into the online polling platform, or you can put it into the Q&A and Cheyenne or Julia will read it to me. But any questions or comments, feedback, what are your thoughts? Mhm. Thank you for saying that. So much depth. I do hope that you got something out of, and I just read the first, I think, like 8 pages. I read page 43 to 51 from chapter 2. Um, but I want you to begin to get a sense of how um, this equal paying, separate care, that we have data to support it. I also go into details about a postpartum study that shows that even when Black mothers report higher scores of pain after cesarean birth, the nursing staff's response to Black women's reports of higher severity of pain goes unnoticed, it gets dismissed. And while white patients report lower scores of pain, they are more likely to be served with opioids. And that data is published. So we have data from the emergency room around appendicitis, the emergency room, and that's with children. emergency room with long bone fractures in adults, and then this postpartum data that shows that there is this white gaze, even if the person's not white, but the white gaze upon Black bodies, Black reproducing bodies, where it's justifiable to ignore us, right? If we are therefore deemed inhuman or not human. So thank you all. If anyone doesn't have any questions, yes, what stuck out to me was I don't think you need this, that I said I'm in pain. Yes. The pain piece really came to I would say life, if that's the best word. It was such a dominant, frequent experience of the 36 Black mothers in Oakland and Los Angeles that was the exemplar that I chose to use to demonstrate the perpetual, unmitigated manifestations of anti-Black racism and misogynoir during the provision of care in any hospital setting, particularly in the emergency room, as well as on labor and delivery or postpartum. Someone else also wrote, "This is so awesome to hear parts of the book read by the author." So it's 8 past the hour. If no one else has any other comments or anything, the session was recorded like the first. We will upload session 2, part 2, onto BCR's YouTube channel. The Educated Birth will also have a link on their website. And I just want to say thank you. So I'll stay a little bit longer, like another maybe 2 or 3 minutes. If anyone wants to say more, I'm going to stop sharing my screen though. And I'll read this last comment. "I think it's hard for people to wrap their heads around their peers themselves dehumanizing others because they don't see the connection between their behavior and dehumanizing." Absolutely. Um, exactly. That's why it's very, very important for me to start chapter 2. So chapter 1 for my book just grounds us in the history of measuring maternal deaths in this country and what the definitions of obstetric quality and patient safety mean. And then I introduced the methodology of my work in 2019. And chapter 2, I started with, although sacred birth quality framework starts with an S, I felt it was important to start with the R, the racism, because I agree with you. Nobody wants to be called a racist. But when I look at your behavior, I don't know what else to call it. And I really, the thread that connects all the chapters together really comes from Dr. Kamara Phyllis Jones' definition, where she says, inaction in the face of, inaction in the face of need, that is the evidence of institutionalized racism. So when the mother says, the nurse told her, "I don't think you need this," and the Black mother's like, "I'm in pain," that's literally evidence of inaction in the face of need. That is institutionalized racism. So essentially, the studies that I share in chapter 2 provide the evidence that neglect is the standard, particularly for neglect towards Black patients, Black adult patients, Black children as patients, Black reproducing bodies throughout pregnancy and childbirth. It's just a standard. So when people across the country are all behaving in the same way, and then how does one come up against normalcy of denying the existence of Black suffering and denying the lack of motivation and empathy to alleviate or reduce Black suffering, which is inclusive of physical, cultural, emotional suffering. Shout out to Dr. Davis. Like that is intentionally causing pain. So I thank all of you all. It is 11 past the hour. I really appreciate you joining today. And thank you. And we'll see you all next time.